Hi, I'm Larry Micarenda, and welcome to this edition of Profiles. And no stranger to the show is Dr. Sanjay Godhwani, rheumatologist. So glad to have you back on the show. So many things have been going on medically in the world, especially with this COVID stuff. And we are really glad to have you back. My first question for you would be, how has the COVID-19 impacted rheumatology?
Larry, thanks for having me on the show, man. It's always good to be back and just to give our audience a chance to educate a little bit more. Obviously, the pandemic has affected medicine all throughout, all specialties. You know, our specialty is a little bit unique. A lot of our patients are already immunocompromised, and they're also on immunocomprehensive medications. So for us, luckily, we were able to get some patients in through telemedicine when we had to close the office. Now things are getting back to somewhat of a normal situation. Patients are coming in and seeing us in person and getting a better evaluation for their joint pain and stiffness. And we're also able to still provide those telemedicine services.
Now, do you have any updates in regards to COVID-19?
Yeah, so there's been a lot that's been going on as far as, you know, the long-term effects of COVID-19. There's been more studies coming out on that. The systemic effects of having the disease, of course. We do know that it's a respiratory disease, and there are some long-term respiratory complications, as well as we're finding out more and more cardiac complications as well.
Now, some of these complications that people are getting from COVID-19, they have mentioned this multi-system inflammatory syndrome, I believe it's called. I hope I'm saying this right. Multi-system inflammatory syndrome. I think that's it. And cardiac involvement?
Yeah, so, you know, they've seen a lot of these cases in younger kids. It's almost mimicking what's known as Kawasaki disease, where it affects the coronaries, affects the heart. You're able to get some fevers, rashes, lymph node swelling that can come out of it. And there's still a lot more research that's being done into identifying who's at risk and who's not at risk for this condition. But yes, there's been well-known facts about coronary artery involvement, heart attacks, so on and so forth, that we're still yet waiting to get more and more information on.
Now, can patients develop autoimmune diseases from COVID?
Yeah, you know, so a key thing about the autoimmune system is anything could trigger your immune system to cause an autoimmune disease. And a lot of times patients ask me, like, well, how did I get this? Like, what happened? There's nobody in my family that has autoimmune diseases. Why did this happen to me? And the key thing to understand about the immune system is that your immune system is built to protect you. It's built in a very complex way. And for an autoimmune disease to occur, multiple things have to happen for your body to react in the way that it does.
Now, with the vaccine, I mean, you know, basically, how is your immune system working with this?
Yeah, great question, Larry. A lot of people ask, like, well, what happens in an autoimmune disease? What's triggering it? So there's two major parts of your immune system. One is called the innate immune system, and one is called the adaptive immune system. And I'd like this example to bring into light is, let's say your body's exposed to a foreign pathogen. We can use COVID-19, the flu, a pneumonia, UTI, anything. Once your body recognizes that there's something wrong, your body's innate immune system is the first line in defense. So they get on the scene, and that's when you start getting some of these fevers, joint pains, rashes, and your body is trying to put that fire out. And what happens is, when you are exposed to something like COVID or any kind of infection, your body then communicates with the adaptive immune system, because now your body is trying to adapt and form antibodies. So the next time you're exposed to the same thing, your immune system is much more prepared in putting that fire out right from the start.
Now, as far as your protection rates with various vaccines are concerned, is it like all for one, they're all going to do the same thing to your immune system, or they work differently?
They all do work a little differently. I think the 2-dose Pfizer vaccine, which is 3 weeks apart, the Moderna, which is 4 weeks apart, and then there's a single dose Johnson and Johnson. The single dose Johnson and Johnson is about 73% effective. Pfizer's got some better rates, about 90 or so, 88 to 90. And then the Moderna seems to be the best at protecting symptoms, and that's about 94%.
Now, there's been a lot of talk now about these boosters. Who should and should not get the boosters?
So, the guidelines are constantly changing. I'm sure you guys are watching this on TV. Sometimes they say wait 8 months and they say wait 6 months. So right now the booster dose has been approved for anybody above the age of 65, and they should get it. Patients above the age of 45 and then they have underlying medical conditions should also get that booster or a third dose. I think certain vaccines are also now being approved for a third dose, and the Johnson & Johnson has just been approved for a second booster, and they're recommending that currently after 2 months. Now, the antibodies, the vaccines, the questions seem endless, and I'm sure every physician and every practice is getting these questions. What we want to try and do is calm and ease some of the confusion. Yes, you can check your antibodies, and there's a specific test that you can use, simple blood test. It's called the spike protein. And then if you remember what the model of the coronavirus looks like, it's a ball with like a bunch of spikes on it. So they can measure some of these proteins in the spike proteins antibodies, and you can quantify how much antibodies you do have. Now, if you've had COVID and you've checked your antibodies, or if you received the vaccine series, you should wait about 4 to 6 weeks at least, because that's how much time it takes for your immune system to form these antibodies. And then we can check them and track them. And if somebody has greater than 2,500 antibodies, greater than 50, greater than 500, depending on the lab, of course. They can wait up to the 6-month mark, or maybe even a little bit longer. But for those patients that are immunocompromised, that have underlying medical conditions, right now the guidelines are saying about 6 months you should get that booster dose.
Now, what are the indications of an immune-compromised patient?
Well, having an autoimmune disease such as lupus or MS, you're already considered immunocompromised. And that means there is a likelier chance that you can pick up an infection, that your immune system may not be able to defend it properly as a healthy individual. And then the medications that we often use, and oncologists and hematologists often use, like chemo medications or immunosuppressive biologics, they do suppress the immune system even further. And we do have to counsel the patients, right? What happened during the pandemic is a lot of people got scared. They were in fear that I'm going to get this virus and I'm going to die, and so on and so forth. And they stopped their treatments. They stopped their medications. And as a result, now those patients that we saw last year, they were lost to follow-up. A lot of them are having flares. Their joints are all swollen. They're very stiff. They're in a lot of pain. We want to have a balance. So patients like that should get the vaccine, should get protected, but at the same time, we can't halt your therapy. We can't halt your therapy because your body is going to cause a lot of ruckus and a lot of inflammation to come back out. And that's what these medications were doing to help suppress that immune system.
Now, how can you check if someone is protected from the vaccine? What tests do they do?
Yeah, so we can do the antibody test, and it's a key point that you just brought up. Is like, what if somebody is immunocompromised and they're on certain immunocompromised medications? Maybe their vaccines won't mount an immune response because we're giving you stuff to suppress the immune system, and at the same time, your body's trying to now create these antibodies. So there are dose recommendations for those that are getting these types of therapies, that we tell them, like, listen, if your infusion or your medication is due, in a couple of weeks, push it back at least 1 to 2 weeks, depending on the medication. Certain medications we do recommend holding for at least a month or two after receiving the vaccine, just so your immune system does mount an adequate response.
Now, the next question is definitely a lengthy one because it's been in all the papers now and it's finally getting some attention. And that refers to long COVID. A lot of
Yeah.
people don't know what long COVID is and regular COVID. It's rather confusing. So, could you explain to the public what long COVID is?
Yeah, so COVID-19, the initial infection, if those, that, and it's terrible what this pandemic has done in general. Of course, we've lost many, many lives, and the rates keep going up and down. There's different variants. There's all kinds of new things that we're not sure about yet. Now, patients who've had the COVID-19 infection, usually you should clear it within a week to 2 weeks. You should start feeling a little bit better. The respiratory symptoms can resolve. And if there are serious cases that patients are, having shortness of breath and their oxygen saturations are dropping, there are antibody infusions that are given to those patients in the hospital to help minimize some of those symptoms. Now, this long COVID has been coming out in the news a lot lately. It's patients who've had COVID and their symptoms are just not going away. They're feeling very, very tired, very fatigued. Sometimes they can still have lingering effects from the infection itself, like shortness of breath, a prolonged cough. People just may develop aches and pains. And again, with any infection, your body's immune system could be triggered. And I have seen patients who've had COVID, now their joints are hurting, they're getting rashes, they're getting hair loss. So long COVID essentially is prolonged symptoms that they felt during the initial infection with COVID-19. Maybe not as severe, but they're lingering longer and longer. And that's what the long haulers or the long COVID means.
Now, there's these connective tissue diseases. And basically, what are those?
So connective tissue disease is a generalized term that we use for certain autoimmune conditions. I mean, the hallmark or the main one obviously being like lupus, but not everybody wakes up and has lupus one day. Not everybody develops a connective tissue disease overnight. Sometimes you may have things called Raynaud's, where your hands turn colors in the cold weather, like white, red, purple. You can get sores in the mouth, problem with your eyes, obviously some joint pain, swelling, stiffness. So connective tissue diseases is a generalized category, and there's so many of them. And as a rheumatologist, as a detective, we try and identify what the signs and symptoms that you're experiencing, with obviously some blood tests to identify if you do have one of these autoimmune conditions and what we can do to go ahead and treat them.
So basically, as a rheumatologist, what's in your toolbox to diagnose all these things? Because you get people can come in with all different diseases. You can't tell, is it COVID, Lyme, connective, arthritis, right?
Yeah,
So,
it's a comprehensive workup. The key thing I always come back to is history and physical exam. Now that we're able to see people and physically examine them, often if I listen to patients, even on the phone, I can tell what kind of pain they're experiencing, what kind of joints are affected, what the pattern of their symptoms are. And then once we examine them and find, oh, listen, you have some psoriasis, oh, you have this rash behind your leg, that helps us. And of course, we have a multitude of blood tests. We do a pretty extensive workup and a panel to identify these things, whether it's Lyme, whether it's lupus, it's rheumatoid, whatever it may be. And then we align those with what you're feeling. And if what you're describing sounds like lupus, your blood work convinces us and shows that it's lupus, then we go ahead and start treatment for those conditions.
I was going to say, because people who have psoriatic arthritis, which is like psoriasis, okay, and to talk about Lyme disease getting the bullseye and rashes and stuff like that, you'd have to be able to tell, which is which, right?
Yeah, with psoriatic arthritis, it's, I think we could probably do a whole show on that, and rheumatoid, just to kind of sort of highlight some of the more advances in those two fields. But yeah, like this characteristic rashes for certain diseases, right? If you've had the bullseye rash from a tick bite, you don't really need any other blood tests. It's pathognomonic. You see it, you know what it is. Same with like the butterfly rash that you get in lupus. And all of these signs, symptoms, again, have to be tied into what you're feeling.
Now, we made the diagnosis. Now, the next step is the treatment.
Yeah.
What are some of the treatments that are available for these diseases?
So in terms of autoimmune diseases, the first step is, again, it's when is the pain? Are you feeling sore or stiff first thing in the morning? You shouldn't really have any pain in the mornings. I can understand we're all getting a little bit older, and you get a little back pain here, a little stiffness there. But if your stiffness in the morning, especially like in your hands, your feet, your back, if it's taking you a good 30 minutes, 45 minutes just to start your day, that should be like a red flag. That you should want to get to a physician and kind of sort of get some workup done in identifying that. Now, once we do identify what's there, and like initially after getting the blood work, so on and so forth, at the same time, I'll either give some anti-inflammatories or some steroids. And steroids and anti-inflammatories, they just help calm down the inflammation, right? And again, if you have kidney disease, I'm not going to give you anti-inflammatories. If you're diabetic, I'm not going to give you high doses of steroids. But a little bit just to check and see if your symptoms improve. That's usually the first step in treatment. Now, once we get all that blood work back, it could take 2-3 weeks to get all these tests back. You've tried these, anti-inflammatories or prednisone. Then we have a multitude of medications. I know you've all heard of the hydroxychloroquine. It's been all over the news with the COVID-19. But that's generally speaking been a good medication for us, for patients with like mild symptoms. And there are other drugs like methotrexate, and then you see all these biologics and things on TV. And in respect to the autoimmune world, lupus has made some advances, and there's a lot of new therapies that have just come out this year for that condition. So we have to kind of sort of cater the medication options to each individual patient. What's effective and safe for them with their other medical conditions, and what's obviously not going to interact with the drugs that they're already taking.
Sort of like a customized menu for each patient, right, that comes in?
Well, it is customized. I think the great thing about our field is there's no two patients that are the same. I'm always being asked, well, why did you choose this medicine for me and not this medicine? Well, this medicine would interact with your other drugs, and I can't give that to you. Our number one goal is still always do no harm. And of course, everyone is worried about side effects. But you have to understand, you have to take control of your health. And if there is something that requires you to be on some medications that are immunosuppressive, and they're going to give you a better quality of life, the main goal is to find that particular medicine for you.
Yeah. Now, with your office and your practice, you guys also believe a lot in natural healings too, like the use of special vitamins and infusions and stuff like that. Could you tell the public a little bit about that?
Yeah, when a big part of just rheumatology in general is we have to combat these conditions in a multitude of ways. Whether it's rheumatoid, whether it's lupus, or even if someone's suffering from COVID-19, and these patients that have this long COVID syndrome, we do like to use vitamins to help with inflammation, such as turmeric, curcumin, ginger, flax seeds. Some of these dietary changes are important because what you put into your gut also controls a big part of this immune reaction.
Right.
And I give patients examples like, listen, you might go out for pizza tonight, and then the next day you're like, oh, I'm a little bit more achy today. So the vitamins that we like to use, like the turmeric and curcumin, obviously folic acid, vitamin D, high doses of vitamin D and C, and even some zinc are being shown to be effective in treating some of these COVID patients and treating their symptoms as well. And then some patients just can't tolerate the oral vitamins. They can't absorb the vitamin C. They have malabsorption or a leaky gut. And for some of those patients, we do offer like intravenous vitamin C or high dose vitamin D. And then we do offer things like glutathione, which can help detoxify your system.
Yeah, and a lot of remarkable research has come out about the vitamin infusions like D and C, and a lot of people don't realize that they have a deficiency, especially from what we've been hearing about D. And a lot of people take vitamin D and then they don't get any sunlight because they hear sunlight can cause skin cancer or something like that.
Right.
And then they don't realize the damage that can actually be done to the system. I mean, vitamin D deficiency, especially in joints, right?
Yeah, I mean, it's prevalent out here in Long Island, I mean, all across. And, I'm not saying everybody has to go in a rush and check their vitamin D levels every week. I think if you're taking a daily supplement, maybe 1,000 or 2,000 units a day, it's typically enough. But if you're low and you need the high dose, then you can take up to 50,000 a week. And sometimes people come back with a vitamin D level of 12 or 13. So we do want to fill their tank first, and then they could take a daily supplement to keep it leveled.
Yeah, because some people might actually suffer from like a malnutrition in the gut, that
Right.
their body's not absorbing the vitamin D or some other vitamins, which causes a deficiency, which causes another problem, which causes them to come and see you because their joints are dying, right?
Yeah.
When people hear the word rheumatology, they really don't understand just how broad of a scope rheumatology really is. Could you just explain that to the public?
Yeah, we are specialists in the field that's devoted to obviously your immune system, to joints, tendons, ligaments, bones. So there's a lot of different conditions we treat, and of course, most of them are rare diseases. But there's a lot of common things that we treat also, like shoulder pain, whether it's an impingement, a bursitis. Is it a rotator cuff tear? Is your hip pain just hip pain, or is it bursitis? So analyzing just the joints, getting a good physical exam in, and then we can send them for imaging if there's certain things that we need to get more information, like an ultrasound or an X-ray, MRI. So fortunately, we have the tools. And I know right now there's a big problem with people losing jobs and losing their health insurance. I always want to just be an advocate for you and your health, that whatever we can do for you and help you feel your best, that's what we're all about.
And I guess congratulations is in order because we heard that you just opened a brand new office in Port Jeff Station. You want to tell us a little bit about that?
Yeah, during this pandemic, I actually opened up an office, and it was a long process just getting everything renovated. Everything took months and months to get. But as of June, we are finally open. We had a little grand opening recently, and we're offering a lot of services there. Obviously, my practice is there. We have a state-of-the-art infusion center, and it's a very, very calming and relaxing feel. So a lot of our patients, you have to understand there's a lot of stress in everyone's life. And if we can do a little something to just help them get back to where they want to be, it's always a good thing for all of us. We do have a little personal training gym in the office, focus-inspired training, one-on-one training. I know some patients are still hesitant to go into large crowds and gyms, but this is one-on-one. Everything is cleaned. We're also offering some holistic care, weight loss programs, vitamin infusions. And I think we're also going to start offering some aesthetics, a little bit of Botox. And we have a wonderful esthetician, Serena. She's going to be doing some skincare. So we want your visit to our building to be more of a relaxing feel and a step in the right direction to get you feeling better and getting you back to where you were before COVID, or even better than you've been before.
Just before we wrap things up, you want to tell the people about the fine staff that you work with. I've met most of them. I really like them. I know you have Kyle and another doctor. I think Greg is his name or everything. You mind telling us a little bit about that?
Yeah, we've been very blessed. Obviously, it's been difficult to find good help, and we're still trying to find more and more staff members. But fortunately, everyone knows Kyle Eskridge. He's my physician assistant. He's been with me for about 3 years now, and he knows the practice. He knows his rheumatology very, very well. So I'm grateful to have his help and support. And recently we just brought on another PA, Craig Orofino. He has 17 years of rheumatology experience. I mean, if somebody knows rheumatology, it's him. So we wanted to have good, smart, knowledgeable, experienced physicians and providers to obviously deliver the best care that we can. Our front desk staff and our management staff is also really, really great. And we just try to bring a nice, calm, and friendly environment for our patients.
And you also have nurses that work with you, right? A whole team.
I have two of the best nurses I know. Ryan, my infusion nurse, and we just got a new nurse. Her name is Martina. And they're wonderful. Patients love them. They listen. They care. And you know, when patients are on infusions, it's nice to build a rapport with the nurse. They kind of know which arm to use for their injection or their infusion. They know about them a little bit. But they're wonderful. Our staff has been phenomenal, and I'm just really, really, truly blessed to have them in my life.
Well, before we wrap up, we did get a question from a viewer,
Mm-hmm.
and I figured I'd leave this for you instead of me answering it. And they wanted to know that we mention infusion a lot, but they don't really know what infusion is. So
Yeah.
could you tell the public what infusion is?
Yeah, so you know, in our field and other fields as well, there's a lot of different medications that treat, you know, the same things. You know, let's say, for example, rheumatoid arthritis, there's all these injections and pills that you see on TV. However, some people are afraid to give themselves a shot. They have a fear of needles. Let's say they can't shoot themselves up. There's tablets that are not working for them. They're giving them GI distress. So in certain patients, we do offer not vitamins, but infusion therapies. And the infusion is you come into the office, you're placed in a nice, cozy, secluded, you know, you're 6 feet apart. There's plenty of space in our office. The nurse places a small IV into your arm. And with that IV, you get your medication delivered right to your system. Some infusions can take, you know, 30 minutes. Some could take a lot longer. And their frequency depends on the drug and the disease. So having an infusion is direct therapy into your bloodstream. Once you're treated, you're gone. We see you back in maybe a month, 2 months, whatever it is. And that's how you get your medication for your underlying condition.
Well, we're basically out of time, but I did want to thank you for coming on. And hopefully we're going to continue our series during the fall and winter. We have a lot more things coming up about rheumatoid arthritis and psoriatic arthritis. So hopefully we look forward to seeing you then, and want to thank you for coming on the show and letting all the viewers know what's going on out there in the medical world.
Larry, my pleasure. Be happy to come back and share more information with our audience. And if there's any questions or comments that you get, you know, maybe we can also do like a Q&A.
Sounds good. I'm Larry Mike Arenda. This has been Profiles. Until next time, stay safe and stay healthy.